Good evening, colleagues. I am Dr. Tsepiso Mfolo from the Paedodontic Society of South Africa. In collaboration with SADA and the PSSA, we bring you yet another exciting and informative lecture by our international speaker, which I will be introducing shortly. Before I introduce our international speaker, there are just a few announcements that I would like to make. Only our panelists have the ability to use the video and microphones, so participants are in listen and view mode only. Please take note that click the Q&A button and type your question. Please do not use the raise your hand option. You can upvote or comment on the questions you would like to hear the answer to the most. So our panelists will answer the most popular or frequently asked questions at the end of the presentation. So please note that, do not put your questions on the chat box or raise your hand. Just put it on the Q&A button, please. That will help us quite a lot. And for this event tonight, it qualifies you 1 clinical CEU point. Just remember as well, we are streaming live in YouTube. So in case you experience any difficulties throughout with Zoom, you may switch over to the YouTube. Certificates, CPD certificates will be loaded to the SADA platform, and you will be able to access all your certificates under your member profile. If you are not a SADA member, you will be able to create a profile to yourself and access your CPD certificates. Please bear that in mind. Reminder to also complete the evaluation after the webinar. I would also like to urge dentists who have a special interest in treating children to please join the Paedodontic Society of South Africa, as we have exciting discussions and also clinical cases that we share between us. So please join the Paedodontic Society of South Africa. I will give you the emails on the chat box later on. If you have any queries or any help with all of the above that I have mentioned, please email pr@sada.co.za. We are so excited and waiting in anticipation to hear our lecture from our international speaker today with an exciting topic that is quite a buzz at the moment. The topic is efficacy of modified bioactive glass for bioremineralization and potentiation effect of silver diamine fluoride, smart art. It is my pleasure to introduce to you Dr. Lazo. Dr. Lazo is from Peru, and it's still in the morning in Peru, and we are very glad that she is able to join us today. She has attended a postgraduate program in pediatric dentistry, and she also has a professor postdoctoral pediatric dentistry program from Lima in Peru. She also is a participant in a Special Smiles Clinical Director by Special Olympics, Inc., and also the internship in pediatric dentistry program from the University of California in San Francisco. She's also a recipient of 3 awards, Best Research about Medical and Dentistry Science from Peru as well. She was also an invited lecturer at the Royal Academy of Medicine and Related Sciences of Galicia, Spain. Dr. Lazo, it is such an honor to have you presenting to us. We are eagerly waiting to hear your presentation. So over to you.
Thank you. Thank you so much. First, good night. No, it's good night to everybody. Thank you to you on behalf of here in this presentation. Thank you to the Pedo Society to invite me for this webinar. Thank you for the presentation. So I will start here. Okay, everything is working well?
Everything is working well, Dr. Lazo.
Okay, thank you so much. So, okay, what I'm going to talk tonight, it's about the new bioactive biomaterials for pediatric dentistry. Especially, I will talk about this new generation of glass iomers, that add strontium. So I will talk what is the benefit of these glass iomers if we compare with the regular glass iomers, and how is the potential effect for the SDF, the silver diamond fluoride. So this is what I'm going to talk tonight for us. And okay, I will pass this. I am from Peru. And the topics for tonight will be first, what means minimal invasive dentistry? What kind of materials work perfect for minimal invasive dentistry? I will talk about silver diamond fluoride, SDF. Then I will talk about biomimetic. What means biomimetic? And especially I will talk about bioactive glass. Then I will talk about this strontium modifies bioactive glass that is inside this new generation of glass iomers. And at last, I will talk about the smart technique that is SDF and glass iomers. Okay, I love to start with this picture because said knowledge is power, and it's perfect because if we know perfect what happened in the histology of caries in enamel and knows that it's different than in dentin, and what happened especially in effective dentin are so different. And sometimes we do the same treatments in enamel than in effective dentin. And this is a big mistake because both are different. And right now, especially in pediatric dentistry, we have another big problem that is it's a big challenge for pediatric dentistry. Right now, we are talking about Molar Incisor Hypomineralization, MIH, and this is a big problem. So right now, I'm going to explain how is the different histology in enamel, in effective dentin, and in molar incisor hypomineralization. And if we know what is happening histology in these cases, we are going to choose the perfect material and we are going to have 100% successful in our treatments. Okay, first, what means minimal invasive dentistry? All this year, we are listening a lot of minimal invasive dentistry. And why? Because we have this problem with the COVID-19 in dentistry and no drills, no aerosols, because we are so scary the aerosols contamination, and maybe it's a risk. It's a risk. It's not maybe. It's a risk for us in our dental office. So we talk about minimal invasive dentistry in the last year a lot. But minimal invasive dentistry is not only not use aerosols and said, okay, I'm going to cover my face with a face shield. And if I'm not use aerosols, I'm not need to use a face shield. It's more. The philosophy of minimal invasive dentistry is more than don't use aerosols. It's the philosophy is first, detection early caries. Second, prevention and caries risk. Third, minimal intervention. Fourth, arrest caries. And the last one, remineralization. All these things is the philosophy of minimal invasive dentistry. So first, okay, detection, diagnostic. Sometimes it's not easy, especially in early caries lesions. In teeth and fissures, sometimes we need to clean well. We need to use loops, okay? Loops are important for diagnostication, for detection of this early caries lesion, okay? So look here, it's a early caries lesion in enamel, no cavity, okay? And here it's another caries lesion, no cavity. The other way is how we are going to detection the proximal caries, always with the Biomimetic. With the Biomimetic X-rays, we are going to have good results for detection. Okay, but what happens if we have, okay, caries lesion in enamel, but is with cavity? Okay, forget the drill, and we are going to use the dental spoon, the dental spoon excavator to remove that lesion. You only remove with the dental spoon excavator. If we have a lesion in dentin, it's easier detection. Okay, all the time the parents calls to you for an appointment because said, oh, I just checked a lesion in my a caries lesion in my kids. Okay, why? Because it's in dentin, so it's easier for detection. And it's good right now to know that minimal invasive dentistry first is, okay, detection, and then is to know how much we are going to remove of this lesion, okay? And in enamel, I explained. And right now, I will explain in dentin, caries in dentin. For minimal invasive dentistry, the suggestion is only remove the infective dentin. Only remove the infective dentin. And we have a lot of systemic review that said is the best option to only remove infective dentin because you don't have any risk for any pulp exposure and nothing like this. So how we are going to do this selective removal of caries tissue? Okay, first we need to know that infective dentin is the soft tissue and effective dentin is a firm tissue. What happened in this soft tissue? We're going to find a necrotic zone with a lot of bacteria, and we are going to find a collagenous fiber degradation. And it's important to know that because sometimes some doctors said, okay, work in the infective dentin, but you're not going to remineralization, nothing if you work in infective dentin. And why? Because you don't have collagenous fibers, and collagenous fibers you need for remineralization, and I will explain. Okay, so in the firm zone, we are going to have a demineralization zone, but it's reversible, this demineralization, okay? So infective dentin is irreversible, denatured, infective with bacteria, with collagenous fiber degradation. So you need to remove all. And what happens sometimes when we are removing? we have this confusion. I am removing all the infected dentin, or is it still? So first, you need like a little training, no, to look the different colors. And when you remove, look here, it's a light brown, it's effective dentin, and when it's a dark brown, it's an infective dentin. Okay, and effective dentin is a bio-friendly tissue. It's great for remineralization and for bioremineralization. Okay, why? Because is in effective dentin, you will find collagenous fever. A lot accounts of collagenous fever, more than in a sound dentin. And this is perfect for regeneration, the tissue. But what is the problem of the past? No, why don't still using for years and years this technique? Because this technique started in the 80s, and what happened right now? No, it's because effective dentin don't have a good adhesion with the resins and with the glass ionomers. And let's check this systemic review of 21 years. In this systemic review, we're going to see how is the percent of successful in ART treatments, okay? And for primary teeth is 24 to 96. And for permanent teeth, it's 43 to 80 to 98. Why this big difference, no? Why maybe I'm going to use, I'm going to do ART, and my successful will be 96. And in which case, my successful will be only 24. What's happening? Okay. First, not all the classic glass ionomers have this 100% successful in effective dentin. And why? First, remember that in enamel, we are going to find 97% of hydroxyapatite, and in dentin, 70% of hydroxyapatite. Okay, so hydroxyapatite is formed for calcium ions and phosphate ions. Both ions are going to unite and form hydroxyapatite. But what happens when we have acid attacks? Okay, from the plague or from the food, what happened with these minerals? You're going to lose these minerals. These calcium and phosphate ions are going to lose, and it's going to happen a demineralization. Okay, and what kind of material, okay, I can use for remineralization? All the time we're only thinking that the only material for remineralization is the fluoride. Okay, so we call to the fluoride, sorry. So we call to the fluoride, okay, for remineralization. But check this picture. Fluoride needs calcium and phosphate to form for formation of fluorapatite. And fluoride alone doesn't remineralization. The remineralization will happen because the formation of the fluorapatite. So the fluoride needs calcium and phosphate. If fluoride doesn't have calcium and phosphate, ions never will form fluorapatite, and you're not going to have remineralization of this tissue. And this is the problem of the glass ionomers. The classic glass ionomers needs that in an effective dentin, you have good accounts of calcium for interaction ions of fluoride with this calcium, and form fluoroapatite crystals that is for remineralization. Okay, this is a problem with the classic glass ionomers. And what is the problem with the resins? Okay, what happened with the resin? Why the resins are not a good option for effective denting? Because in effective denting and in a denting, we have a proteins, enzymatic, that's called metalloproteinases. The metalloproteinases are enzymatics that degradation, okay? And they are in the dentin sleeping, but you can wake up using an acid. So if you are using a resin, you will maybe in some case add orthophosphoric acid and you are going to wake up. But you can tell me, Rocio, but I have universal adhesion or self-adhesions, but these have two acids. So these acids wake up these metalloproteinases. That's the reason that resins doesn't work well in effective denting. Okay, let's check this case. Look here. Why the resin doesn't work in this case? Because okay, they wake up the metalloproteinases, and these metalloproteinases degradation the adhesive, and of course secondary caries, it's there. Okay, let's check this paper from Dr. Domenico Ricucci, no? And Dr. Domenico Ricucci said, I'm not agree about minimal invasive dentistry, and I am not agree to remove the infective dentin and work in defective dentin. So why Dr. Domenico Ricucci said that? Because in his research, he applies resin in defective dentin. And look here, the same that happened in the case that I show you is the same that happened in Domenico Ricucci cases. Look here, what happened? Metalloproteinases wake up, degradation of adhesion, and of course, secondary caries. Conclusion, no resin fillings in effective dentin, because this is what happened, okay? So I present both case, classic glass ionomers and infective in effective dentin, doesn't work well, and resin fillings that doesn't work well in effective dentin. Let's talk about MIH, Molar Incisor Hypomineralization. That is the big challenge in pediatric dentistry, no? It's crazy that when you receive a patient with MIH, okay, first the patient came to your dental office because they want aesthetic. They want aesthetic, no? It's uncomfortable with the color of the hypomineralization. Second thing, because it's so porosity, because we have, in these cases, less accounts of calcium, this enamel, it's easier to broken so easy with the occlusion forces, okay? It's another problem. A third problem is because it's porosity, it's you're going to have more risk to caries lesions, okay? So you're going to have both things, hypomineralization and caries. The other problem is the hypersensibility. The hypersensibility, it's crazy. I know that you have the experience that have a patient with MIH and hypersensibility, and it's so crazy for these kids. You can touch with the mirror with nothing, with the dental mirror, nothing. And the other problem is the adhesion. The adhesion is worst. It's worse. And why is worse adhesion? Because this enamel is less accounts of calcium and phosphate. Perfect. So what happened histology in this hypomineralization? Okay, enamel deficiency of minerals, it's 20 to 25%. Okay, so if we remember the picture that I show you, the enamel 97% of hydroxyapatite and dentin 70. If we compare hypomineralization, it's more similar with dentin than with enamel. Okay, so don't try to say that enamel and treatments that you are doing in caries in enamel is the same to do it in hypomineralization enamel. Okay, you can happen with this high porosity and the high risk of caries to find, of course, caries solution too. And what's the other problem in hypomineralization, in molar incisor hypomineralization? It's not only the problem in enamel. The problem is in dentin too, because you are going to have more sums of interglobullar dentin. And what happened in interglobullar dentin? In interglobullar dentin is slightly less mineralizate. Okay, so no mineralizate in enamel, not good mineralizate in dentin. Let's check here. That's the reason that glass ionomers doesn't work well. Okay. Okay, so what kind of materials are going to work well? Because if we all the time thinking, okay, the good material for hypomineralization is glass ionomers, and we're checking that it's not. What kind of materials are good for hypomineralization? What kind of materials are good for effective dentin? For enamel, it's easier, but for effective dentin, no. And for molar incisor hypomineralization, no. So what kind of materials are working well for minimal invasive dentistry? Is silver diamond fluoride, 38%, and bioactive biomaterials. Both are going to work perfect. Okay, this is the silver diamond fluoride, 38%, that it's perfect for minimal intervention, caries arrest, and remineralization. And we have this new generation of glass ionomers with the strontium that is perfect for minimal intervention, arrest caries, remineralization, and bioremineralization. And the other technique that is a smart technique, that is when you are mixed both things, SDF and a glass ionomers, you are doing a smart technique that it's perfect too for minimal invasive treatment. First, I will talk a little bit about SDF. In the last years, we are listening a lot about SDF. All the time suggest, okay, for minimal invasive dentistry, SDF is great for arrest caries. And SDF is not a recently material. It's for years and years. Maybe more than 50 years ago, it's working and used it in Japan, in Brazil, in Argentina. And why right now we are listening a lot about SDF? Because in the 2050, FDA approved in the USA the SDF, okay? And approved the SDF for a treatment for sensitive teeth, okay? I work in this research with Dr. Peter Milgram that helps to the FDA to accept the SDF in the United States. So this is the the research that helps to introduce the SDF in the United States. What is the composition of the SDF? The composition is silver ions that are good because are antimicrobial, the sensitivities. They have amino and fluoride for remineralization. Okay, if we compare SDF concentration of fluoride with the fluoride varnish that are using often, compare the concentration. The ppm is double. Okay, and the American Dental Academy suggests that the best material for no restorative treatment for caries lesion is SDF. Better than fluoride varnish, better than Recaldent, it's perfect. So let's talk about no restorative cavity control with SDF. This is a case of a patient of 2 years old, and let's check. This is a caries lesion in this first primary molar. The option was a no restorative cavity control with SDF. And after 12 months, look here, remineralization, great results in this case. Why we have great results? Because the penetration of the SDF is so good. We have a good penetration in the interprismatic zones and it starts the remineralization, okay? Sometimes we said, okay, it's great SDF, but what happened with the color? The color is dark. And try to don't be, that the color is not going to be a problem, you can add a Ka, that is the potassium iodide, that it's great for that you don't have this dark color for the SDF. And the other good thing is that in patent fissures, for example, there are sounds, no? This SDF with the Ka, it's not going to dark the patent fissure. So it's going to be good. Look the penetration. If we decide to use it SDF for patent fissure, it's better than if we use the sealants, okay? Because the penetration is really, really good, okay? And for proximal caries lesion, SDF is another good option. Look here, this case, the caries is in enamel, okay? Is in enamel. Don't look this that is in dentin, only this that is in enamel. So I use it the SDF with the Ka for don't be so dark. And look this follow-up of 6 months. Look here. It's remineralization. Only in 6 months, remineralization, caries lesion, proximal caries lesion, if we use SDF. Okay, let's check here. You have here another case with proximal caries lesion. So if you have this kind of case, it's good if you can put orthodontic separators. Why? Because if you have this if you use these orthodontic separators, then you will have a good access for the proximal caries, and you're going to check well if it's cavity or not. And it's going to be easier if you want to apply the SDF, okay? You can apply with the dental flow, okay? This is the dental flow from Oral-B, or maybe using this micro brush, these points from SDI company, that it's perfect. Look here, if you want to use the Oral-B flow, dental flow, or if you want to use it, the micro brush of SDI company. Look, it's in both, you're going to have good results. I prefer the micro brush because I don't have any risk for maybe the kids move and I can paint the face. Okay, this is the case. And let's talk about no restorative cavity control in ineffective in denting, okay? So in this case, I used the SDF, and look, after 12-month follow-up, great results, remineralization, okay? Why? Because the penetration in denting, it's better than in enamel, so it's good. What is another property of SDF? It's a great inhibitor of the metalloproteinase. Do you remember metalloproteinase that we are crazy because if we add orthophosphoric acid, we're going to wake up and this will degradation the adhesive. Okay, an inhibitor of this effect is the SDF. Okay. The penetration of SDF in dentin, it's great. It's better than in enamel. And for that reason, this systematic review suggests that it's better for varnish or enamel, and for dentin, it's better SDF. But my problem is not the color. The color is going to work if you put the eye, you're not going to have problems, okay? If you want to use the smart technique, no? For example, in this case, we have open caries in dentin. We remove the infected dentin and we work in the effective dentin with the SDF. In the upper, look here, we used the combination of SDF and Chi-I, and look, no risk with the color. But if only use the SDF, we are going to have problems with the colors and we're going to have these problems with the restoration. Look, the follow-up, 6 months, 80 months, everything is working well. We can use it, the SMART technique, with sealant. Yes, SMART technique is not only with glass ionomers. SMART technique is first SDF and then applies any adhesive material. Can be glass ionomers or maybe sealants or resins. And you will have good results. For example, in this case, this is an enamel caries, and I prefer to use the SMART technique with a resin, with a flow resin. And first I apply the SDF, then the Chi-A, and after the Chi-A and dry, I apply the universal adhesive. This universal adhesive that I don't need to use the orthophosphoric acid. So I apply the universal adhesive, photopolymerization, and then the flow resins. So this is another SMART technique. So SMART technique is not only with glass ionomers. I repeat, you can do it with resin. Okay, so the problem is not the color. The problem is not if you doing no restorative or restorative with the SDF. The problem is that the penetration, that is a high penetration. If you work with the SDF close to the pulp, you will have problems because maybe will happen a necrotic, okay? So this is the disadvantage of SDF if you are thinking to work so close to the pulp. Look this case, and okay, it's a necrotic pulp. I did to open the chamber, no? And look here, look the penetration, and this is why necrotic is pulp, because the silver necrotic pulp. So be careful, don't use it so close to the pulp. So if I am close to the pulp, what is a good option, no? It's the biomimetic biomaterials or the bioactive biomaterials. So I want to talk about this new philosophy for dentists, biomimetic. And what means biomimetic? Biomimetics means to copy or mimic nature. And what we are going to mimic? We are going to mimic the biomineralization. And what means biomineralization? All the mineralized tissues as the bone, enamel, dentin, are mineralized and development this high mineralization because they need first a organic matrix. These organic matrix are going to crystals the calcium and phosphate ions and form the hydroxyapatite. So to form hydroxyapatite, we need this organic matrix. We need, for example, collagenous fibers, okay? That is biomineralization. So why biomimetic is going to mimic? It's going to mimic this. Biomimetic needs organic matrix. It's different than remineralization. In remineralization, you add a lot of minerals, no? In this case, fluoride. But you don't need the organic matrix. In this case, you need the organic matrix, okay? You don't need if the tissue has calcium or not, you need organic matrix, okay? This is bioremineralization. So biomimetic is not recently, it's years ago in medicine is working a lot with bioactive biomaterial, with biomimetic, and Dr. Larry Hench in 1969 development the first bioactive glass. That it's the composition, it's calcium silicophosphate glass. And this used in medicine for bones, okay? For regeneration fractures in bone. And I will show you this video to explain a little bit how it's working, these bioactive biomaterials in bone.
Human beings. Human beings are fragile. Accidents, injuries, traumas. The human body can regenerate itself, but sometimes it's not enough. Implants, prostheses, and substitutes are often necessary to rebuild osseous structures and help the body to regain its functionality. Bioactive glass contributes to bone growth. It can be used in a wide range of medical applications. Like here, in the case of bone filling, the material is put into the bony defect. Just a few hours after the implantation, ionic exchanges occur between body fluids and bioactive glass. A biological fixation is created between the biomaterial and host tissues, leading to a solid grip within the osseous site. This fixation becomes a silica gel and gradually mineralizes into a calcium phosphate layer. The composition and structure of this layer are identical to human bone. The fact that silica and phosphate concentration are increased around the material causes a genetic activation, which induces a differentiation and proliferation of osteoblasts. These osteoblasts are the actors of bone remodeling. "100% synthetic, therefore 100% safe, bioactive glass is biocompatible and bioabsorbable. All its bioactivity lies in its ability to transform itself and, in the end, to become completely assimilated by hosts. Hosts, or rather, human beings."
Okay, this video explains a little bit of how works this bioactive biomaterial. Okay, so for biomimetic is going to do it bioremineralization or biomimetic remineralization. And for this, we need biomaterials that will be bioactive. What means to be bioactive? Bioactivity means to stimulate regenerative engineer of material and tissue interface, okay? And this philosophy is great for minimal invasive dentistry. So it's so good. It's so good to use it for minimal invasive. So somebody with the audio open. Okay. Okay. What we are going to talk about enamel. Enamel, it's formed for prisms, and the prisms are formed for hydroxyapatite crystals, and these hydroxyapatite crystals are formed for calcium and phosphate, okay? So when it's development, the enamel, it's the ameloblast are the principal cell for development of the enamel. What happened? These cells, I don't know what happened. Somebody opened with the
Okay, Dr. Lazo, Maralise most probably would sort it out. I would just advise just to hang on just a little bit while we sort out the problem, because there is really that feedback from the back. Okay, so I think we should just wait a little bit.
Okay, I will wait a little.
Okay. Right, in the meantime, while we are sorting out this problem, can I have everybody's microphone muted? And please put your questions under the Q&A for us so that we can be able to attend to all of the questions that you might have had. Please do not put your questions under the chat box. Put them directly under the Q&A option, please, because we need to sift through the questions you might have for Dr. Lazo. Right, we apologize for that negative feedback. We will get to it just now.
Okay, it's okay.
I think we can continue.
Okay, okay, I continue. So,
sorry about that, Dr. Lazo.
No, something happened, I don't know. Okay. Okay, so again, enamel is formed for prisms. The prisms are formed for hydroxyapatite crystals, and the hydroxyapatite crystals are formed from calcium and phosphate, okay? What about is the development of enamel? Okay, the cell is the ameloblast. The ameloblast are going to secretion a protein called amelogenina. And the amelogenina is so important because it's going to do the transportation of the calcium and phosphate or secretion of for the ameloblast to the organic or to the organic matrix. And in the organic matrix are going to crystals these calcium and phosphate ions, and it's going to form hydroxyapatite. Okay. And so at first, enamel, it's not so with so much minerals. It's only 50 to 20% of minerals. After this biomineralization, the ameloblasts are going to degradation the protein that is the amelogenin. And the amelogenin will be only 1 to 2% still in the mature enamel. And when finished this work, ameloblasts go away. No more ameloblasts. So if we are talking in a mature enamel, right now, you know that you're going to have 97% of hydroxyapatite and only 1 or 2% of organic, that is the amelogeninase, this protein, that will be in the interprismatic space, okay? What is the role? What is the role of the amelogenins? The amelogenins are going to receive the calcium and phosphate and help for crystals, these ions of calcium and phosphate ions, and form the hydroxyapatite. Okay. What happened in dentin? In dentin, the things are easier for bioremineralization, because remember, for bioremineralization, we need organic matrix. And in dentin, we have 20% of organic matrix. So it's great. It's better than in enamel. And the other good thing is that in enamel, you only have 3 proteins. The principal is the amelogenin, but you only have 3 proteins. In the case of the dentin, in dentin, you have a lot accounts of protein, different proteins, that will be great for regulatory the odontoblast. That the odontoblast is the cell that develops the dentin. Okay, this is bioremineralization, is what we are going to mimic. And what kind of materials are bioactive? And this is the 3 big families or bioactive biomaterials, okay? The first family is the nanohydroxyapatite. This is the first family. The other family is the enamel proteins. And the third family is the bioactive glass, okay? Today, we're going to talk only about the bioactive glass, okay? The bioactive glass, it's, I know that you know about MTA, no? MTA is a bioactive glass. The bioactive glass, it's formed for calcium silicate, okay? 3 calcium silicates. And these things, this bioactive glass needs hydration, okay? If you have the powder, you need water for hydration, okay? The first bioactive glass for dentistry that it's approved from FDA is the MTA in 1998, okay? How works this bioactive glass? How works the bioactive glass? Let's check this video, okay? Look here. This is the bioactive glass. The bioactive glass be in contact with this. This is the collagenous fibers, okay? And adhesive to the collagenous fiber be there, and then it start to throw away all the counts of calcium, because remember this bioactive glass, it's formed for calcium, 3 calcium, and okay, throw away, give a lot of counts of calcium. If you give a lot of counts of calcium, what is going to happen with the pH? The pH will be high. Okay, we are going to have a pH of 12. And this is great because this is an inhibitor of the growing of bacteria. So it's perfect, okay? And after we have a lot of counts of calcium, what is happening? Remember, the proteins that are in dentin are going to wake up and are going to stimulate the odontoblast to form again calcium and phosphate ions. And in that moment, the proteins are going to transportation this to the organic matrix, the collagenous fiber, and in that moment, it's going to crystallize the calcium and phosphate ions and form new hydroxyapatite crystals. This is what is towards this bioactive glass. And this is why they are doing biomimetic, bioremineralization. They are mimic the bioremineralization again. The same that happened when development the dentin is the same that will happen, okay? So it's great. We look here, the bioremineralization, the new crystals of hydroxyapatite are big and strong. Let's check these papers that compare a classic glass ionomer with this bioactive glass, and look how is the bioremineralization. Let's check in this case, okay? If I ask to you, what was the pulp diagnostic of this second primary molar, maybe you can tell to me, okay, maybe it's a reversible pulpitis, okay? But if we check the preoperative x-rays, look here, necrotic pulp. And with an internal rib resorption. Look here, this is an internal rib resorption. And in this case, okay, the first permanent molar is not yet. So I decide to preserve this second primary molar, okay? So to preserve, I did LSTR treatment, lesion sterilization, treatment repair, therapy repair, that I use the triple paste that it's metronidazole, ciprofloxacin, and minocycline for only 3 days, okay? First, I open the pulp chamber at the same as a pulpotomy. It's the same as a pulpotomy. Then I apply this triple paste and a cotton and whatever IRM material. And after 3 to 5 days, I remove everything. I remove the triple paste and I apply to this pulp chamber a bioactive glass. In this case was biodentin. Look here, after 9 months follow-up, repair the internal rib resorption, okay? 20 months follow-up, great results. 30 months follow-up, great results too. This is a case that if you have in your dental office, the first thing that your first treatment will be extraction. But look here, with the bioactive glass right now, you can do it, this treatment in necrotic, and you're going to have 100% of successful. Remember the inhibition of bacterial growth. Remember that. Okay, high the pH. We have here another case. This is a patient of 6 years old, came to my dental office because the mom was crazy with this first primary molar. The other pediatric dentistry are doing the classic treatment of pulpectomy and still the fistule and still the fistule. And the mom calls me and said, Rocio, I want an appointment for extraction. So he said, oh, for extraction. Okay, I will check the x-rays. And check the x-rays. Okay, I said, why extraction? And the mom said, please, extraction. I said, no, I can extraction this. Please give me 2 more appointments for this treatment. The mom and the first mom said, no, no, no. And I explained, and it's okay. She said to me, it's okay. So I did the same, the LSTR hook therapy, that is lesion, sterilization, and treatment. No instrumentation, no. And then I used a bioactive glass. Okay, let's check what happened. 6 months follow-up. Perfect regeneration, repair, perfect after 6 months. Okay, 80 months follow-up, still everything perfect. Clinical and x-rays control are perfect. Okay, 30-month follow-up. Okay, it's the regular reabsorption, no? The regular reabsorption of the primary molar. And 38 months, everything is working, but I decide to do the extraction because the kid will going to move to live to Spain. So I prefer to do the extraction. And check here. Look, the perfect sealing of the bioactive glass are perfect. Okay. So let's check. This is another case that has this necrotic. I used the bioactive glass. In this case was neopathy that is pre-mixed. And let's check the x-rays. This is the preoperative, and 1 month to check how it's regeneration, deletion, okay? You have good results. But the problem with this bioactive glass is the setting time, and it's not a permanent restorative. So it's this is the problem, no? You need that, okay, applies on the top a restorative material that will be maybe glass ionomer or maybe a resin. So so right now, if we want to use it, a restorative that has the properties of a bioactive glass, we have the new generation of glass ionomers. This is the new generation, and these glass ionomers are so different than the classic glass ionomers. And why? Because these are bioactive glass that add a strontium. And why is it important to add the strontium in a glass ionomer? Okay, remember that for work well, the glass ionomers, no, the classic in effective denting, we need a good account of calcium to interaction the fluoride with the calcium and form the fluorapatite. But we don't know if we have the good accounts in our effective denting. Remember that in effective denting, we have more organic matrix than in a sound denting. Okay, so in this case, forget if we have a lot account or no accounts or nothing of calcium, because these glass ionomers add strontium, because strontium had the same properties of the calcium. If you look here, it's in the same line of the calcium, strontium. So it's perfect for try to do it remineralization, because the fluoride that needs the calcium for form fluorapatite. In this case, with the strontium, doesn't need the calcium, and it's going to form strontium fluorapatite. Okay, it's perfect. So it's the perfect substitute of the calcium. Strontium is the perfect substitute. So this is a modified bioactive glass with the strontium. Look here, look, it's have good results in new hydroxyapatite crystals. Look here. And I explained to us the same with the fluoride. Strontium and fluoride are more strong than with the calcium and fluoride to form fluorapatite. In this case, you'll form strontium fluorapatite and you'll have great results. Okay? So this is what happened.
It is essential that the glass ionomer is placed while it has a glossy surface. The gloss is free polyacid, which is able to penetrate the cavity surfaces to form a strong, hydrolytically stable chemical bond to calcium ions within the dentin and enamel. In addition to chemical adhesion to calcium in the tooth, a fusion bonding process takes place as well. Calcium and phosphate ions from the polyacid-treated dentin and enamel, and strontium and fluoride ions from the unset glass ionomer intermix and precipitate, forming an interface called the interdiffusion zone. This zone is stronger and more acid resistant than either the glass ionomer or the tooth. The combination of the interdiffusion zone and the chemical bonding provides the basis for a strong, stable adhesive interface and creates a bacteria-proof seal for the cavity, best described as a chemically fused seal.
Okay, so this is how works the strontium. And we have this new generation glass ionomers with the strontium, 50% of the strontium, that is a good percent, for have these good properties to when we use it, okay? This is the Riva Light Cure, high viscosity, that have strontium, and it's perfect, works perfect. And look here, this is a Riva Light Cure, that it's a glass ionomer modified with resin, with fluoride and strontium, okay? If we have this, if we want to do it a minimal invasive treatment, for example, here, we're going to remove the infective dentin, and we are going to work in the affective dentin, okay? Then we apply the Riva Light Cure, high viscosity, and look here, it's perfect aesthetic, and X-ray, it's perfect. Look here, it's sealing perfect. It's not the same that happened with the resin. In the resin, the problem is that metalloproteinasas are going to degradation, the adhesion. And here we are not going to have problems with the metalloproteinasas, and we are going to have great results. Okay, look here, it's another case. The follow-up is 24 months and works perfect, this material, this new generation of glass ionomers. If we're working in enamel, look here, this is in enamel. Okay, I prefer to use it, Riva Light Cure that is not high viscosity. So the regular, no? So it's going to be more flow for pit and feature caries. Look here, perfect. And what happened with the molar incisor hypomineralization, okay? Remember that molar incisor hypomineralization is the same, no? That happened in affected dentin. We didn't have good accounts of calcium in this tissue, in this enamel. So we need to add calcium. But in this case, we are not going to add calcium. We are going to add strontium. So if you want to do it a restoration in a hypomineralization and in a molar incisor hypomineralization tissue, use it a glass ionomer with strontium to have good results. A glass ionomer of the new generation. Look here, the follow-up, 2 years, using the Riva Protect, that is this is glass ionomer sealant that have strontium and perfect adhesion. You didn't have any problem. The follow-up 24 months, perfect. And in this case, when it's the cavity, it's big, it's more open, I prefer to use it, the Rival Light Cure High Viscosity. Look here, great results. Look here, it's perfect. The sealing, it's perfect. Why? Because you are at strontium, simulate or changing from the calcium that needs this tissue, that needs this hypomineralization enamel. Okay, another thing, talking about this new generation of glass ionomers at the strontium. Right now, do you remember that the problem of the SDF is not just so close to the pulp because the silver may be necrotic, the pulp. But the silver is great because the silver, it's first antibacterial and second inhibition of the metalloproteinases. So in this case, I will present to you a glass ionomer that has strontium and silver. That it's perfect because it's going to work better, and it's the Riva Silver. The problem with the Riva Silver, it's a little bit the color, okay? So look here, in this case, first, the treatment was with resin ineffective dentin. Of course, didn't work well. And look here, caries lesion, in secondary caries lesion, okay? And I changed this resin for this glass ionomer with the strontium and silver, okay? If I want aesthetic, you can remove in the second appointment the this Riva silver, and then you can put on the top a resin, so you have aesthetic and perfect aesthetic from this patient. Look, the follow-up, 9 months, everything is working, it's close to the pulp, no necrotic, nothing. At the last, a smart technique with the combination of SDF and a new generation of glass ionomers with a strontium. It's great, the combination for a smart technique. And for example, in molar incisor hypomineralization, if the patient has a lot of sensitive, you can use it, the SDF for sensitive, and then close the cavity with good results with this glass ionomer with a strontium that will help to be the good adhesion for these lesions. So it's another alternative for the treatment of hypomineralization. If the patient have a lot of sensitive, if the patient don't have a lot of sensitive, it's okay if you only use the glass ionomer with strontium, and it's perfect. Only if the patient have high sensitive. Remember that the SDF is the best for control the hypersensitivity. Okay, thank you for pay attention this night for this presentation, and thank you again for inviting me to talk to us tonight.
Thank you very much, Dr. Lazo. That was such a comprehensive and excellent lecture. Thoroughly enjoyed. Thank you very much. We can tell actually by the number of questions that you'll be getting. So I must just say there is indeed that paradigm shift from the curative approach to the preventive approach. And this terms of minimum intervention dentistry or minimum invasive dentistry, as it's sometimes called, has gained quite significant popularity over the days. I've just been in a global symposium where we talked about those terms, and we discussed procedures like the whole technique. We talked about the SDF and a whole lot of ways in which one can be able to restore the tooth and not necessarily using invasive methods. So particularly, I was very pleased to see your presentation and you addressing some of the questions that we might have. But I will quickly cross over to the Q&A, where our attendees have posed a number of questions to you for you to answer. So I'll start with the first one, which is quite a popular question, especially with the advent of SDF. As we all know that SDF has a few side effects, but one of the most popular side effects is that discoloration that it brings. And I know in your lecture, you alluded to it, that you put the potassium iodide, then it lessens the staining. But there's a question here. They say, even with the smart technique, the staining is visible. How do you convince parents to accept the staining from the SDF?
Okay, first one, this alternative is when the kids are, for example, so little. So if you have two options, maybe sedation or not. And the parents prefer the color, prefer the staining, than a sedation. So this is the first thing. Second thing is, if I cover with a glass ionomer, for example, I apply the Cayetano, and the Cayetano, the color is not going to be so dark than if I not use it. So this is why I present to the parents, no pictures, and said, okay, this will be the color. Are you agree about this? And the parents said, I prefer that than sedation or maybe general anesthesia. I prefer this kind of treatment. So SDF works perfect, for example, for little kids or for special patients, no, that it's not easier to do any treatment.
Yeah, and I would also like to add that there was also a study that said that if you engage the parents and you tell them about the procedure and what is going to occur, they are more likely to take and expect that the staining is going to occur and not have that great expectations. So I think communication is a key.
And show pictures, yeah. And so the parents said, okay, it's okay. And then you're not going to have problems. Sometimes I prefer that the parents signed, I am agree about the treatment of SDF. So you are not going to have problems in the future that said, oh, I don't like this. Nobody explained to me.
True. There's another question here. Do you etch and bond prior to applying the SDF? I guess that speaks to how the material works, but you can go and take this one. Do you etch and bond prior to SDF?
No. Why? Because the penetration of the SDF, it's so high. So if I before applies, I applies the orthophosphoric acid. Okay, I'm going to potential this penetration, and I don't like to be more. No, because I have maybe the risk for necrotic the pulp if I am so close to the pulp. So I prefer that, and it's okay if I don't use it and I have good results for remineralization.
Great. Even on the manufacturer's instruction, you just place that SDF directly. You don't etch or bond before applying that SDF. And then there's another question here. Which clinical codes do you charge when using SDF? I guess our codes are different, but in South Africa, I know that there's no specific code for application of silver diamine fluoride. So at the moment, practitioners just apply it as like a desensitizing agent, or they put the code for topical fluoride application. In Peru, what do you do, Dr. Lazo? Do you have a specific code for SDF application?
And no, in Peru, for example, if I using the SDF, we are using a lot the SDF in Peru, especially in public health, because it's okay. It's the same here in Peru. We are a third world country, so we have people that don't have too much access for dental treatment. So it's better to use it as SDF, no? So you're going to control. In these cases, we use it a lot, the SDF. And in the private practice, I try to explain to my patient what is the benefits, no? What are the benefits? And the difference with fluoride varnish, no? A fluoride varnish has limits, no? And SDF not. So in the case of caries lesion that are proximal caries lesion, that the color is not, it's not a problem. I use it a lot in proximal, and I have good results. The tip is that, okay, use the orthodontic separators. So you're going to apply so well the SDF. If you want with the oral flows, or if you want this micro brush from SDI, are good for these cases.
Yes, there was another question on when you apply those ortho separators, do you use local anesthetic? But I assume you don't. Do you use local anesthetic?
No, nothing.
You don't, yeah. We don't use local anesthetic when you are applying those separators. And another question here says, SDF application, do you use it once or several times?
Okay, this is a protocol. It depends. For example, if your patient is a patient that have poor, that doesn't brush the teeth, it's crazy, you are going to use it each 6 months, okay? So 2 times in a year. But if your patient have a good clean of the teeth and they have too much plaque, you can use it only one year, each 12 months.
Okay, great. There's another question. I think this will be our last question because of time. Will SDF work as well in permanent teeth with deep carious lesions?
Yes, it is the same in permanent than in primary. It's the same.
It's the same. All right. I will just take in one more. Are dentine conditioning agents required with these new GI materials?
No. Why is the reason of use it before a condition? Because the condition gives to you the option to have more calcium in the tissue. That's the reason that you use a condition, no? And in this case, you don't need the calcium because you have the strontium in the glass ionomer. So you don't need.
Great. So I just like to say thank you.
Yes. So the steps are only one. Applies direct. Yes.
Great.
So it's fast for pediatric dentistry. Yeah.
Yeah, quick and easy. That's what we want. Hey, effective, something that works.
Of course. We don't have time. We don't have time with the kids. With the kids, we don't have time. Only the kids is you, okay? The first 10 minutes or 50 minutes, but then the kids wants that, I want to leave.
And another thing is that it's cost effective, so which makes it so ideal, you know, to use the SDF. We've come to the end of today's lecture series. I'd like to say thank you very, very much, Dr. Lazo, for the great presentation. We really, really appreciate your time. And thank you for such a comprehensive lecture. It will be available on YouTube for those who have missed parts of your lecture. And I hope we will be joining soon, not on a virtual platform, but on a face-to-face platform in the near future. And you will visit our country as well, hey? So it was really great to have you here with us.
Thank you so much for inviting me. Thank you. Have a good night.
Have a good evening, Dr. Lazo. Thank you very much.
Yes, for me, even if for you, nights.
For you, it's during the day, but yeah, for us, it's a good night. So have a good day further. So without, in the interest of time, I would just like to thank you for attending this lecture series. Remember that we have another one next week on the 30th of March. So it's one of the 4 lecture series organized by SADA and also the Paedodontic Society of South Africa. Please also look at on the chat and join the Paedodontic Society of South Africa, where we have a lot of interesting cases. I'd just like to say thank you very much for your time, and we'll see you next time. I'm just going to put on a screen which will show you how to join the Paedodontic Society of South Africa. Thank you very much. So if you're not a member, please, here are all the resources that you need to be a member. So we hope to see you in numbers joining the Paedodontic Society of South Africa. Thank you.
Thank you, ladies. I'm going to end the meeting now. Goodbye.